Hi, and welcome to this short lecture series on clinical decision making. This is part 1 of 3, an introduction to clinical decision making theory. My name is Alan Gardner. I'm a senior lecturer in advanced clinical practice at the University of Central Lancashire. So the aim of this session is that throughout the three parts to this lecture, we're going to be exploring the thought processes that support clinical decision making. So in particular, we're thinking about how we structure our thoughts and what thought processes we use in order to form a diagnosis when we're presented with patients with new problems in particular. So to start with then, we're considering the clinical method, which is the methods that we use in order to actually generate a clinical diagnosis. And first of all, we need some context to this, that a lot of what we think about in terms of diagnostics and clinical medicine in a contemporary context comes from the work of William Osler. He's seen as the father of modern medicine. He was a Canadian physician who revolutionized our approach to medical education, in particular by bringing students, medical students in his time would spend most of their time reading books and studying the course of disease theoretically. And he was the first person to bring medical students to the bedside to actually interact with patients and really stress the importance of history taking and getting to know our patients and be able to understand their lived experience of disease. And it's through understanding our patients' experience of their own illness that we can then start to draw parallels between the patient we have in front of us and the patterns of presentation that we see theoretically, the evidence base that suggests that that particular presentations relate to the underlying pathophysiology and that manifestation of disease. So William Osler is attributed to several memorable quotes that still ring true today, and in particular you might have heard this first one. If you listen to the patient, they'll tell you the diagnosis. That's actually a slight disambiguation of what he said originally, which was listen to your patient, he is telling you the diagnosis, but obviously that now sort of spans our cross-section of society, that is our patient groups. And what this is trying to tell us is that the information that we get from our history and from a comprehensive approach to history taking, or at least an approach that allows us to ascertain the pertinent information, that allows us then to use that information, or really it's very helpful to see it as data, that although we take a very person-centered approach to the actual process of history taking and our consultation skills and our use of the therapeutic relationship, that actually once we have the information from the patient, that it's then data for us to use and to interpret in order to reach our successful diagnosis. We've also got this idea with this second bullet point then, that medicine is a science of uncertainty and an art of probability. So what he's getting at with that then is that we need to be familiar with or comfortable with uncertainty and understand that when we talk about diagnoses, you might hear people refer to a definitive diagnosis, but actually I challenge that notion, that it's more useful to consider that we have a working diagnosis. And we'll see as we start looking at the process of clinical decision making and how we structure our thought processes in order to actually reach a safe working diagnosis for a patient, that we should be constantly questioning ourselves, and that it's a constant cycle of gaining more information and questioning, or do we have the right diagnosis, especially when we're faced with very complex patients, but in particular as well when we're faced with common presentations, so that we constantly question ourselves, well, are we getting the right diagnosis because we're seeing patterns, but what do we actually do when we're faced with something unusual that kind of fits our usual pattern, but it is actually something more rare or more unusual. And so it's about us kind of dealing with this uncertainty and understanding that the majority of the time our most likely diagnosis is the most probable one, but that we shouldn't really see it as definitive, that we should always question whether or not we really have the right diagnosis, and do we have the right information or the right data available in order to support our theory, that theory being that well, we think that the patient has is having an MI, or that we think the patient has appendicitis, that becomes our sort of theoretical solution or answer to the question, well, what's actually causing the patient's problem? And then we've got this this third bullet point here, that it's more important to know what sort of a patient has a disease and what sort of a disease a patient has. So he's alluding to this idea that traditionally doctors in his during his time were taught purely the theory of disease, but he stressed the importance of actually understanding what our patients look like, and so understanding that a patient will present with a certain set of symptoms and signs, and that we understand what that set of signs and symptoms looks like in a patient, how it manifests within people, rather than trying to fit a disease theory to our patients in front of us. He wrote in one of his books that to study medicine without books is to sail an uncharted sea, but to study medicine without patients is to not go to sea at all. So what he's stressing there is this importance of being very patient focused and understanding that the clinical context of our knowledge. But what we'll see throughout this series of presentations actually is that there's very much an interplay between our clinical knowledge as well as our understanding of the theory of, well, how do we actually form a diagnosis, and how do we use that knowledge, and how do we access it as well. That's going to become very important, being able to access that knowledge rapidly and in an organized fashion. The context in which we're considering clinical decision making isn't just in regard to all the clinical decisions that we make, but we are thinking specifically about how we form a diagnosis, and that's what we mean by clinical decision making. Although you make lots of different clinical decisions, obviously, throughout your daily working lives, we're thinking specifically about, well, how do we actually form a diagnosis? Reflecting on my own experience of moving into advanced clinical practice, I remember early on in my own master's degree in advanced practice, I'd observed my clinical facilitator, and she could reach a diagnosis on very small amounts of information, and so I'd kind of observe her and just think, well, this is some sort of alchemy. How on earth does she manage to reach a diagnosis just based on such a small amount of information? And she was a fantastic clinician. But most importantly, I think really at the stage at which you're at in your journey is to start to understand your own thought processes and those of other people. So to be able to understand, well, how do I actually reach that diagnosis? So a brief definition then of diagnosis. It comes from two Greek words, dia and gignoskein, meaning to tell one thing from another, to tell apart two or more different possibilities. So we're trying to identify the nature of a particular problem, either by the process of elimination or using other analytical methods, or as we progress through this presentation, you'll see that there's other sort of more automated ways that we can reach a diagnosis. So we're referring to then the determination of the cause of a patient's illness. So we're trying to essentially sort of pin a label, or that's what we mean by a diagnosis. So we're pinning a label on a particular presentation or a set of signs and symptoms that we know that a particular illness manifests in a certain way, and so we can use our clinical knowledge and the information that we get from our patient in order to reach our conclusion as to what our diagnosis is. With regard to the diagnostic process, then, it's about understanding this intangible process within our own minds and within that of our colleagues. And I think that this is something that isn't always explored that well clinically, that to actually understand, well, how did someone interpret the information that they get? So on the left of the screen here, we can see that it's about interpreting the data from our history, our physical examination, as well as laboratory data and x-rays, but really clinical diagnoses are very much about understanding our real essentials, which is our history and physical examination. There's several studies that you'll be able to find that suggest that about 80% of diagnoses come from the history alone. So essentially we're talking about good quality data coming from our history. We use our physical examination to confirm and refute the information that we get from our history. And then we further refine our data collection through blood tests and other laboratory tests or x-rays and other clinical investigations. So we say on the bottom left here, this is what we mean by obtaining our data. Then what we do in our minds is to interpret it, and there's several strategies that we're going to look at throughout this short lecture series that help us understand, well, how do we interpret that data in order to get to our diagnosis. But as I've mentioned before, that this is actually a cycle. So we continue to obtain data and we continue to interpret it as we access new information. We have to consider how we interpret and respond to new information, and as I said before, start to question, well, do I have the right diagnosis here? Especially just being kind of self-aware that you can become entrenched in one particular solution to the problem or one particular diagnosis, and then fail to respond to new data that questions whether or not you have the right or most appropriate diagnosis. So that's why we need to see it as this cycle where we go back to obtain more data and interpret that and question, well, how does that affect the diagnosis that we have? Now we get to an actual definition of clinical decision making. We've talked around it, but to actually define it succinctly, we can understand it to be it's quite a complex activity, and so that's probably why it can be quite difficult to define. That it actually requires the underpinning knowledge of presentations of disease and an awareness of how we actually structure our thoughts in order to reach this diagnosis. So it's defined as choosing between alternatives, and we've used this word differentiating, or you'll have heard the term a differential diagnosis, which is about choosing between two or more diseases with a similar presentation, and deciding, well, if two or more diseases or illnesses present in a similar way, for example, appendicitis and cecal cancer can both present with right iliac fossa pain, but they're two very different diseases with very different outcomes for patients. So we need to be able to actually apply not only our data gathering, but the way we interpret that data in order to reach a decision as to whether or not is it appendicitis or is it cecal cancer. But this is a process that does become easier and more manageable with experience. So the difficulty is how to get started on this journey of forming diagnoses, especially in the early stages of developing your clinical experience and developing your clinical knowledge, and starting to actually organize the information that you have access to. So we know then that this becomes easier and more manageable as we gain more experience, even if the processes that people go through to gain or to get to a diagnosis become more intricate and probably more difficult to define, which is why I was saying a few slides back that it's probably something that isn't discussed an awful lot clinically, because with more experience, people tend to use more sort of automated thought processes that they're not always aware of. How, if you ask a very experienced clinician, how did you reach the working diagnosis? Getting them to pick apart their thought processes can be quite difficult because they're basing it on these ideas of pattern recognition, which we'll get to in the second of these three short videos. Just to summarize, with regard to clinical decision making, it's the thought processes involved in analysing what the problem is. So we have patients who come with a particular problem or a presenting complaint, whether that's a sore throat or chest pain or shortness of breath, and then we decide what we can do about it. So through that we decide, well, first of all, we need to actually decide, well, what's causing the problem? And like I said before, that a diagnosis is this label that we pin on a particular set of signs and symptoms. A patient with shortness of breath and purulent expectorate, they're coughing up lots of green expectorate, they've got a raised temperature. We start to then add this clinical information, becomes our argument as to what we think the problem is. That we might argue that this is a pneumonia. And so then we can use that decision as to what the problem is or what the diagnosis is in order to prioritize what we're going to do about it, and then evaluate the outcomes for the patients. And like I said before, this is a continual process. This gets us to the end of this part one. In part two, we're going to continue to build on this theory of clinical decision making by looking at some more specific examples, in particular models that you can use, as I say, as I've alluded to, structuring your thinking in a particular way. So how do we actually start to be a bit more pragmatic about this? I think probably so far we've been fairly theoretical as to what clinical decision making is, and then we can start to actually look at some more pragmatic ways of applying that to our practice. This reference list here is the reference list for all three of these videos, and you'll have access to this on Blackboard.